Doc, I'm having a challenge. And the doctor is actually telling me that he's having a problem with reading and ECG. And
now you are saying that they should also focus on the clinical.
yeah.
How is that practical? You are in school. What do you learn? Like, that's the question some of us were wondering, like, how? Hello, welcome to another episode of my Chat With series, where I spend time with some seasoned guests who come to share their thoughts and experiences when it comes to pharmacy practice. Today, I'm very fortunate to have with me Dr. Anakin, who happens to be a senior colleague of mine, and he's someone that we, as in my batch and even my juniors, look up to. So I'm very, very happy to have Dr. Anakin here. Dr. Anakin, you are welcome to this show.
Thank you, Dr. Obed. I think the last time we met, we all didn't have the doctor title, but we thank God that we've come this time.
Yes, for the sake of my audience who may not know you, can you kindly introduce yourself?
Okay, well, I'm Dr. Anakin Jeremiah. I'm a PharmD holder, and I work with the Eastern Regional Hospital. And I'm currently part of the major or the main preceptors for both PharmD students and also Pharm interns and sometimes MCAs. And I do most of the clinical work here with respect to a pharmacy practice in the Eastern Regional Hospital.
Yeah. Okay. All right. That's nice to hear. So you mentioned that you do it most of the clinical work. So when you talk about clinical work as in a PharmD or a pharmacy doctor, what does it actually entail?
Okay, so you know, the moment we mention a pharmacist, the idea of drugs or medications come to play. And drugs are very, very delicate. Okay, so there are so many things that we can do as PharmDs, but I would share personally from my experience when I started practicing. I mean, it's results from maybe dose of drugs, administration of drugs, to a whole lot of things. But currently in the hospital, what I do is that one, I make sure that most drugs are reconstituted very well. That was one of the challenges that the nurses were facing in some of the work. A typical example was before I came here, they used to administer clindamycin to these children, for possible infections.
Okay.
But after every administration, they had to change the line or get a new line. And the children were also crying and, explaining they had pain. So when I came, that's what they told me, that is their major challenge in the world. So I said, if that's the case, I'll look into it. So I went there and asked them that, so how do we constitute your clindamycin? From then we're just taking the amount and dilute and we just push it through. So no, that is where we have it wrong. That is why we are having these challenges with them, because the dilution of clindamycin should have a particular concentration. And below that, you expect that it comes with pain and phlebitis and a lot of things. Okay. So what I intended doing was that I called for a meeting for that particular ward. I taught them like students, did all the calculations for them, and ever since we've not had that challenge again in the ward. So that is one of the major things that we can be looking at. Okay, administration of medications. You know, nurses have been working for a very long time, but sometimes the administration becomes a problem. So ever since, if there's any drug that needs to be administered, I'm called upon to make the final test before it is done. Okay. If they also have challenges with other medications too, they book me from almost every week. I have a meeting with them, like a classroom meeting. Maybe taking clindamycin, taking gentamicin, taking iron sucrose. You do all these things to make sure that everything is done on the ward. So this is just one of the aspects I just do. As a clinical pharmacist, in the hospital. Okay. Nonetheless, getting to the higher levels to make cases of electrolyte imbalances. A typical example was we were on the ward and they said that this lady had hypokalemia. So that's low potassium levels. So the doctor said, let's give 40 millimole in 200 mils of normal saline. And I said, doc, I think that, just saying that is not the best. But first of all, we need to find our potassium deficit. And there's a calculation there we have to go. Exactly. So we don't really do that. I said, oh, are you sure? I said, yeah, I'm sure. Then I think you have to do a presentation and let us know all these things. So that was my first time I had a presentation with a doctor. So I really did a very good presentation for them. And the norm of doing just 40 millimole in 200 mils of pharmacy line down to the whole story. So for a case of electrolyte imbalances and any other thing, I mean, they just call on you to help them. And you also have to have meetings with them so that they can also learn from you. You might not be there almost all the time. These are just a few things that we do on the work. There are a lot of things that we drag interactions. I make sure that if I come to work, I make sure that the ward that I make sure I look through every word medication. Medication receive medication, as the frequency of the medication be administered. Is any possible drug interaction? You talk to the patient. What are your major concerns right now? Is there any problem that you're facing? So I can say there are a lot of things that we are doing that that also in the clinical practice, and this is just a few of them that I want to just share with you. Maybe in the course of our convo, more of them will pop up.
Wow. So this is quite interesting, and as you mentioned, you scheduling time with the nurses and educating them. I had a similar encounter just last week where a nurse came to me and I was engaging her, and she mentioned that, so you people, when are you coming to educate us on some of these medicines? When you come here and you inform us about it. So I also happened to meet furosemide. They given furosemide, and I think they were going to give over 100 milligram, and they were just giving it as a direct IV instead of giving it as an infusion. So that's when I came and I informed the nurses that no, with this, when the concentration goes above 80 milligram, you have to do it in a form. You have to give it in a form of infusion. So I very much agree with what you are saying, and I think every other person who is practicing should also try and adopt the strategy of engaging these other practitioners so that we would eventually get the word out there and the right things will be done. I'm very happy with the way you enlisted some of the practical things that you are doing. And then it brings me to a question that you are a PharmD or a Doctor of Pharmacy holder. And if you want to compare and contrast your role in the hospital with that of the B-Pharm holder, what do you say is the main difference? If somebody completes B-Pharm and another completes PharmD, what actually differentiates the two?
Okay, so basically the major difference, that is what I'll have to say. That's the major difference. Okay. I can say emphatically that if we should go to the ward, a PharmD and a B-Pharm, what the PharmD might see, the B-Pharm might not see, in the sense that if there are possible drug interactions that are to the higher level, it's not the normal CPRO and antacids, and no. But I mean, drug interactions, the B-Pharm might not be able to see. And you see, the PharmD actually equips you, I mean, more or less like a doctor. But I always say this on any platform that it all depends on you, the individual. Okay, the reason I'm saying this is because, in Ghana, everyone that wears a lab coat, every man that wears a lab coat is a doctor.
Is a doctor.
Exactly. And every lady in the hospital is a nurse. Exactly. And on my lab coat, I have Dr. J. Anakin on it. So they are not concerned about a professional bit of it. What kind of doctor are you? And when they see you as a doctor, you are a doctor. They expect you to know. So someone can just rush to you with what? With an ECG. Someone can rush to you with an MRI. Someone can run to you with CT scan. Someone can run to you with an X-ray. How then do you interpret this? But you bear with me that for our time in school and even doing our practice, these things are not part of pharmacy.
Yes.
Do you get me? So I always say to myself that, you see, but when you start practicing, these are the very things that comes to you. Anytime you enter the ward, if you take 10 patients, 9 out of them have what? ECGs. How do you interpret these things? And you have to be very useful to the team, because you have to know all, because when it comes, the ECG is fine, it's not fine, there are P waves, there are these waves, and like you stand there, you have nothing to say, because you don't even understand all these things. You get it? So what I always say is that I had to sit back, make sure I learned ECG, I learned X-ray, I learned CT scan. I am not perfect, but with the little that I have known, I really changed my practice as a family.
Wow.
The notion of the doctors is that they'll come and go. So now you are a doctor in pharmacy, and they don't know the difference between. They think that they have gone to school for 6 years. We also going to school for 6 years. Also have the same curriculum as they have, but we do more of the drugs. But they have no idea that we don't do this radiology and radiography in school. We don't do those things, but they expect you to know. So you can be there. I have so many friends here, so they can come and ECG. Oh, Charlie, doc, I'm having a challenge. A doctor is actually telling me that he's having a problem with reading an ECG. And so if you sit there and if you don't know, how then can you help this person? Do you get it? And sometimes, you see, I always tell people that if you want to go somewhere, you prepare yourself for the journey.
Exactly.
Okay. Because sometimes on the ward, a typical case, for instance, was we always say that nifedipine should not be given to people with CCF, congestive cardiac failure. Amlodipine is, the best. So there was one time that our patient, as the patient came in, the patient was hypertensive, but the hypertension led to CCF. So CCF secondary to hypertensive was heart disease. But this patient was already on the nifedipine. So they were not so sure, so they had to run an ECG. When they ran the ECG and they came, they checked, and it was just a house officer checked and said everything was okay. But when I realized, no, there were some abnormalities with the ECG. If there are abnormalities with our ECG, then that means that we cannot be giving our nifedipine in the CCF. So I had to make an intervention on that. But bear with me that if I had not learned these things
to read the ECG,
how would I have made this intervention?
That's true.
You get it? And it's rather unfortunate that our curriculum has not covered these things. But some of us, we haven't reached there, but we are doing our best because we spend extra time learning to fit the teams that we find ourselves. Because here we have about 5 specialists. And at any point in time, I go on ward rounds with 2 of them. And you should know, if they are specialists, you should understand their depth of knowledge about what clinical stuff.
Exactly.
So you also have to, at least, brace yourself for what is coming. So with the comparison of a B farm and a farm B, the difference is typically the clinical aspect. Where maybe we cannot give a particular dose in a particular condition and other stuff. In CCF, our maximum dose for Specialization should be 50 milligrams. But in chronic liver disease, we can give about 400 milligrams. Sometimes a B farm might not be able to see these things, but a farm will be able to see these things. So the only difference right now is just about the clinical practice and how exposed you are to the patient and how you can interact with your patients.
That's interesting as well. So you keep mentioning that you had to learn a number of these things by yourself, and we know that in school, if you are in school right now, the curriculum is so packed that you may not even have time to study other things. Then one thing that I really remember is an article that you wrote and pasted in the class and on our faculty. And the title of the article was, "It's not all about first class." However, we want to strive for academic excellence. We want to do well academically. And also when we come out of school, we also want to be good practitioners. So how do we achieve that balance, trying to focus on our studies to make sure that we do well in school, and also when we come out, we also excel in practice? How do we go about that?
Well, I think this has taken me back to my days in 3rd year, because I remember, it was this 3rd year intention that actually sparked this writing of this article? Is it all about first class?
Okay.
So what actually happened was that I in this same hospital, I came here with about 4 other colleagues of mine when we were in 3rd year. And then we had done synthesis of paracetamol in the lab. And we know that p-aminophenol is one of the impurities in the synthesis of paracetamol.
Yeah.
So we're on the ward rounds, and one of the specialists asked one of the pharmacists who was taking on Riser, so who are these people? Oh, these are PharmD students that are here to do internship. And he asked, so what do they know? So they know a lot of things. So the specialist asked us anyway that, so what do you know? What drug do you know? And one of my mates said, oh, paracetamol. Okay. But amongst that, there was one lady who was a first class student back in school. Okay, but I was a first class, but my first class student, but my average was not that cute as hers was. So people really knew this lady that this is a first class student. So, and you see, when that happens in school, you feel that the first class students are much more superior to some of us who don't have a first class. So when the questions were coming, we said, oh, then she's a first class, she has to answer all these questions for us. So we stood behind. So he said, so the specialist said, so what do you know about paracetamol? So paracetamol is used for management of pain and fever, and it's okay. And the specialist asked a question: what makes paracetamol toxic?
Okay.
But remember, I told you we had that synthesis of what? Paracetamol in the lab. So now she said, oh, because it has an impurity cause of p-aminophenol. And from that time, I really realized that, no, this lady was wrong. Even though you had the first class, man, you are wrong. I said, hey, are we safe?
Oh, wow.
This is are we safe? I know the answer was Napi and Amana and the opinion imbi. That's what makes it toxic. But the lady said it was p-aminophenol. So like, I was surprised. Charlie first class student, class down. So after the ward rounds, like specialist got pissed. So 3rd year. So what do you do in school? You don't know anything, and you are standing here. If you cannot contribute to my team, don't come for ward rounds. No one was pissed. I felt so bad. I said, hey, are you? But then too, we did some heart failure, and we were told that the maximum dose could be around 80 milligrams or so. But they asked another question, well, maximum is 80 milligrams. And they don't say, hey, are you sure? And we said, yes, we are sure. He said, no, we don't do that. You learn book and come and stand there. We don't stand there. Oh, but from that day, I went home, I couldn't sleep. So I asked myself a question. I am also a first class student. But here I find myself in the very job I'll be doing for the rest of my life after school. Is this the kind of knowledge I need to have when I'm practicing? I spent so much time in school reading handouts, reading notes, doing lab results and others, writing lab reports and other stuff. Is this going to equip me with the knowledge I need to practice? So I said, no, I have to change. And I tell you, it wasn't easy for me. I mean, I always say that it's only a superhuman that can have, a first class and also be very good clinically. It's as though both of them are contending with each other for you to love one of them. And the moment you love the other goes down. So I realized that when I came to school after my 3rd year internship, I wasn't learning for class again. I was just looking out for clinical things, learning clinical things. And obviously it affected my seat and my habit. So I was dropping. But right inside of me, I was very happy because right now, if I should go to a ward, I am able to really appreciate and apply what I've learned because I was now doing the clinical stuff. But one lecturer came in, he knew me personally that, hey, it's as though nowadays you are relaxing. Why? Your average is falling. I said, Prof, I understand, but I think that is the best for me. He said, oh, you have to be the first class, maintain the first class. I was just trying to advise me. But I just realized that no, it's not about first class. It's not like if you can have the first class, but you come to the field, you cannot practice at all. And I always say jokingly that let's just assume we are all working in a rush shuttle area at KUST. Someone falls down and collapses. They are looking around, they can't find anyone. They see, oh, you are in your lab coat, and they say, oh, you are found. Doctor, please come and help us. But meanwhile, yes, you are a first class student. The first class there cannot save the individual's life. It is your clinical knowledge that can save the individual.
Okay.
So that is what actually sparked, the writing of this article. That, true, let's strive for academic excellence, but don't do that at the expense of your clinical practice, for which you doing rest of your life.
Okay.
I came here with one friend of mine. She is a first class student, but trust me, it was hard for her to step to the ward.
I see.
For the whole year, I was the only one going to the ward, but she was a first class student. And it just confirmed what I had written some years back. And I could always say that I saw the vision long ago. So I prepared myself towards the journey that I was supposed to embark. Although people will say, you are not becoming a lazy student, you're not becoming bad, you're not becoming bad. But today, the school is even sending students to the hospital, and I am training them. If I had just focused on doing my first class and other stuff, no, it wouldn't have helped the students as it is right now. And besides, the way I'm practicing, you might think that I'm a first class student. That's why I'm practicing like that. But I just want to give hope to people that are not in the first class criteria. Okay. If you don't have a first class, that doesn't mean that you can't do well. As I sit here, I don't have a first. When I tell people, they say, "Hey, are you sure?" I say, "Yes, go and check my record." I don't have a first class. I only had to sit down and learn. I always want to motivate people. The fact that people are striving for first, that doesn't mean if you don't have it, that is the end of you. I have so many friends, and people can bear witness that they don't have first class, but they are very good. When it comes to clinical practice, you can't take anything away from them. They are very good, and they can teach and teach very well. So it is a bit of a challenge, Obed, for you to do both. But look at where your interest is. Look at where your interest is. If you think that you don't want to become intimidated on the ward, please give your clinical practice some time. Don't focus so much on your handouts and other stuff. Always look out for the clinical bit of it and combine it. It is very challenging, but if you make up your mind, we will get there. That is what I can say on this topic.
Wow. I have a follow-up question, but before then, with the first class issue, I think recently when we graduated and it happened to be virtual and the names were coming, we just wrote, okay, they started mentioning those who passed. Then we have Dr. So, Dr. So all these people passed as doctors, and there was no categorization into first class or anything. So I think sometimes some of the students are not even aware of the fact that nobody is going to care about whether you had a first class or not. And as you kept saying,
thank you very much for chipping that in for me. I think it is me.
Okay. If I go to the ward right now, or a patient comes to me and there are two pharmacists there is no way this patient is going to ask, are you a first class holder?
Obviously.
But if the patient comes to you and you're able to prove to the person that you really know your stuff, definitely they would always want to stick with you. I have several patients who come and they want to take your contact because of how you explain things to them. And exactly. So I agree with you. However, the question I want to ask is, now you are saying that they should also focus on the clinical.
Yeah.
How is that practical? You are in school. What do you learn? Like, that's the question some of us were wondering, like, how? What actually should I learn in order to improve my clinical practice? Because the information at my disposal is what I'm learning. And
true.
In learning that, I am looking forward to also doing well in school. But if I now want to focus and also do well clinically, what should I actually do?
Okay. Thank you very much. First of all, I want to tackle this in two parts. Okay. I have taught a lot of students from KNUST, and so when after teaching them, I feel bad. Why do I say so? Because when they come, I take them for ward rounds, we see the clinical cases, we discuss, and they understand it very well. But I feel bad because when they come back to school, there's nothing like clinical practice. It's virtually theory. They go and they come back. Oh, you see, so the last time when you guys were here, we discussed, if you used to remember,
They've forgotten.
no, we don't remember. We were at school, we're writing lab reporting. I felt so downhearted. Okay, but what I want to say is that I'm taking this from two aspects. I think that we should change our curriculum for family.
Okay.
Yeah, that is my suggestion from the years of practice and experience I have. I think that we should start our clinical as early as possible. You know what? I had the opportunity to talk. They invited to talk to students from UHAS. Okay, those doing Doctor of Pharmacy. They invited me over to give me a speech. I mean, on the clinical practice and other stuff. And it was so amazing how their curriculum is. They start right from year one. They go to the ward right from year one. Wow. So it is something that it is something that is with them. So it's something you can call university pharmacy is the top notch. All right. And I think that UHAS is taking over. You put a university student, fourth year student, you call a UHAS student, second year student, and it's almost virtually the same. They all know the same things. And I'm surprised. So I had to go to the school myself, ask them, and when I saw their curriculum, man, I was surprised. Right under my nose, I was even here in the hospital. Their lecturers came from the school. They stood by their students and they asked them, we are marking you, dispense this drug. How do you dispense this drug? They were right by their students to see whether they were giving the right thing. And I was so impressed. So impressed. So that is one of the things. I think that we should also look at trying to at least inculcate a bit of clinical practice right from the onset. Okay, so that it becomes part of that. Or else we only take clinical practice maybe when you get to 4th year, 5th year, 6th year. And that alone is not enough. Because after all, when you come to do internship, you're not coming to do theory. Especially when you speak the word, and we have nothing like theory there. It's more practical. I think that we should be looking at these areas in the near future, that the curriculum should change and we have more clinical practicing pharmacists teaching us. That is why they convey what is on the word to the students. It becomes part of them. If they give their handout, read it. They're going to read it and understand whatever is in there. So if the practicing pharmacist comes from the word and gives you this handout, it's the same thing that when you read it becomes part of you.
I agree.
But the other aspect is with the students, and I think this is very, very, very difficult. But let me tell you one thing I did, and that's the secret I want to share with you. I made friends with people that are like-minded like myself. Friends like Dr. Joseph Tebi, Anointing. He's a very good friend of mine. Obed, Dr. Obed Amponsan is a very good friend. You see, these were people that I really love to be with. They understood the clinical. So I go read the paper, I discuss with Anointing. So what is this? What they say? So there's a counter paper that. So we shared the clinical side. It was something that was with us. Anytime we met, it was more of clinical and nothing. So it was something that was keeping us day in and day out. Even though we even read our notes or our handout for our exams, we were still discussing what clinical was stuff amongst ourselves. And in fact, it was something that really helped me. You see, it was part of you, and you couldn't even forget some of the things that you learned because you had a friend who was also like you, was interested in what you were discussing, more of the clinical aspect than the theoretical aspect. And I think that this is what I can only say to all students: get groups, people that are like-minded. If you think you want to understand the clinical, get some of these groups, sit down, discuss some of these things. Just meet an hour for a clinical discussion. That alone is enough. So actually, that's the secret I want to share with you. This afternoon, it was one of the things that actually helped me. I maintained a clinical until I finished, and I had too much love for the clinical practice, and I just fell in it. So those are the two things. The students themselves forming groups of clinical presentations, and I was also very, very impressed when I was back in school. We used to have this, I don't know what you call it again, those Wednesdays meetings on clinical sampling. Sometimes I used to come over to just share my experience, and I was very, very happy that such an initiative was available. And I think that people realized that the clinical was also very, very important as of that tender age at the school. So this is what I just have to say about that.
Wow, those are very laudable. And just to add to it, because of Corona, and we had to going back to school to write our final exams, we couldn't finish our last rotation as we were supposed to. So they brought the practitioners, as in the clinical pharmacists, to school for 2 weeks to be teaching us the very rotations. Like, we're put into groups depending on your rotation, so that the practitioners will come and teach. And we saw a vast difference in terms of the content they were giving and how they were even delivering it. Because this is where when they tell you something, they show you practically what is done, and not necessarily what the book says and what you need to read for the exams. And I actually enjoyed that 2 weeks. In fact, even after sitting in the class, if you don't go and sit down and read again, you are sure to answer their questions and get it right, because even the questions that they were asking was more clinical. So if you have appreciated what you were taught, it became easier for you to answer. Unlike our previous set of questions that you definitely have to read the book, cram it in order to succeed. So I think the secrets that you have shared are very laudable, and every student watching this, or will be students watching this, should really pay particular attention to that. All right, so going on, I want you to help me answer a few questions that some of the audience have asked. And one question that I got is, right now that you are talking about your clinical being on point, it definitely goes with you knowing much about the medicines, so that at any point in time you can offer value when it is needed. So how the question is, one, must you know about every medicine in the world? Then how do you go about learning these medicines so that you don't forget about them?
Okay. Well, with the first question, that must you know all medications? From my point of view, I would say yes and no. Yes and no, because perhaps you don't intend practicing in the country. Okay. And we have some group of medications that we use for the management of these are common medications that we use for the management of our common cases on the wards. Okay. You have to know. But perhaps you might have the opportunity to travel outside. And remember, their practice out there is different from our practice. But I will say that it is best for you to just have an idea of what that particular drug is and focus your strength on what you are using in your country. That is what I do. And I always say this on any platform, that I recommend this book, Lexicon. And I'm not going to hide it from anyone. Lexicon has changed my practice ever since I started studying that book. Trust me, all the presentations I have done for the doctors, I've done for the nurses, I got all these things from the Lexicon. And I make sure almost every day I read this. I read almost every drug that I encounter. But the difficulty is how to retain it. That is the difficulty. And let me tell you one thing. I mean, as I said, I knew where I was going, so I had to prepare myself for this journey. It got to a time that during the long vacations in school, I didn't go home. I was always on campus learning. I was on campus learning the clinic. The theory. I made sure to take this condition, learn. And it got to a time that I had done a lot of reading, and I said, I've not done endocrinology. So I just took, hyperthyroidism, thyroid disorders. So after reading it, I felt that I had to practice. It's interesting, I had to practice this. Would you imagine I had to take a car, call my director at Tamale, Dr. Hamid, I was coming to. I just needed a case to work on so that this became part of me. So this is how far I went. I went to Tamale Teaching Hospital. Went there, looked for a case, and I practiced. And trust me, from that day, I have never read thyroid disorders again. Wow. I had never read it again, but it was still part of me. And sometimes we need to make that sacrifice. You see, because when you read and you don't practice, there's a tendency for you to forget. So there are certain medications you use it commonly. We keep on using it as part of you. But there are others you have to sit down and read. But when you come back, you have to search for a case that is related to the medication and practice, or else you easily forget. Forgetfulness is part of every student or every practitioner, and that is why most doctors will make mistakes. So they write a prescription and you just look at it and say, no, this is not right. You have to go and see the practitioner. Yes, the dose is supposed to, oh, I forgot. So it is something, if you don't practice almost all the time with what you've learned, it becomes a challenge. Okay, so for the medications, try as much as possible to learn as many as you can, but learn what is within your country or learn what is within your standard protocols and be a master of it. Because it's not going to make sense if you know about medications that are used outside the country or outside the used in America, and you don't know what is used here where you practice. It doesn't make sense in that way. So you can learn, just read where you have to free time, just read about some of these things, but make sure you master what you need as your standard protocols. Okay. And with the issue of trying to recall, one thing about me though, every student I've passed through, this hospital will tell you that Dr. Anakin reads almost every day. Obed, I read almost every day. Thanks be to God that there is miscase. I just have to do a quick reference. I can be going somewhere, just have to do a quick reference, and I make sure I read almost every day. And for someone like me, I know the more I read, the more it sticks. But I have to attach the practical bit to it when I have the opportunity. But that is me. I don't know how people can decide to write notes, paste it in their rooms every morning when you wake up. They recite it at the back of my mind. It was something that I used to do, but I realized that it doesn't really help me a lot. Or you can have a notepad. You have it, or maybe today, so I'm like, just read that. Anytime, just flip over, they come back. Flip over, they come back. So the issue of trying to retain this, I think that it's an individual something. Yeah, exactly. Look at the strategies that you think they can employ to help you retain as much information as you have read. But for me, this is what I do. I read almost every day. I try to write some of the things down. When I'm less busy, I can put things down, just trying to recall. If I cannot do that, I go back to visit again and come back again. So as I said, it's more of a personal or individualized something, but anyone can just employ strategies that can help him or her.
Okay. So I agree. I totally agree with what you have said. And one thing that I can take from it is that we need constant exposure to the medicines for them to stick.
Exactly.
Whatever strategy the individual is going to employ, they have to always make sure that at least you are seeing it in use and you are also learning about it so that it sticks and you are able to practice with it. All right.
Affirmative, bro. Affirmative.
Thank you so much for the answer. The next question an audience asks, a member of the audience asks is that just like the medical doctors specialize, do we have specialization for pharmacists?
Yeah. You see, gone are the days we used to have what we call the West African College of Pharmacists. Okay, we used to have West African College of Pharmacists, which is based in Nigeria. Okay. But currently we have the Ghana College of Pharmacists.
Okay.
Now, if you enroll in the Ghana College of Pharmacists, meaning that you are moving to an area of specialty. Okay, so there are a lot of areas they can specialize in. There are a lot of areas they can get with this current. The school of what's the name? School of Pharmacy right now. There are major areas they can specialize in, but it takes not less than 5 years. Okay, you do what we call primaries for 2 years, and you do fellowship, and they become a specialist in that area. So whatever area you want to, you can specialize, provided they have. See, it's something that is new. They have people in the system that are already specialized. But to the best of my knowledge, I have seen that they are adding more areas to the specialty. Okay. And currently I have one pharmacist here right now. She wants to really do oncology. As it stands right now, they are trying to find lecturers in those areas or resource personnel in those areas that can help you when you get to that level. Okay, so there are a lot of areas that can specialize. Cardiovascular, nephrology, You can do endocrinology, a lot of psychiatry, and a lot of areas. There's an area you can specialize in as of now. Yeah.
Okay. So, right after the PharmD, do you need to do any other thing before you can specialize?
Oh, I think before the PharmD, if you want to even do further studies, you have to wait for about 2 to 3 years of practice, or you have to practice for not less than 3 years before you can be enrolled in any area as you want in the clinical field.
Okay.
But the PharmD, based on the structure of PharmD, you can, just after your housemanship, you can enroll to move into the area of specialty. And I think that it's a very good thing. Looking at the content of the PharmD, they think that it's an upper hand. You don't have to really do so much of the practice before you can move into those areas. So as it stands right now, some of my mates have even enrolled in the Ghana College of Pharmacists, moving to the area of specialty. As it stands right now. So that is it. So you don't have to do much. Just know your clinical stuff and you can move on with that.
See, that's soothing to hear. I hope the person who asked this question will enjoy the answer that has come out. Okay. So before I let you go, is there any other thing you would want to say to the audience, primarily anyone who wants to venture into pharmacy school, or who is looking forward to getting into pharmacy school, and those who are already in pharmacy school, and even for those of us who have completed and we are now getting into the practice?
I think I can talk about a lot of things with this last bit of it, but I'll just make it snappy. I always tell people that I won't ever hide anything with respect to the practice of pharmacy from any pharmacist or any potential pharmacist or any student. I wouldn't do that. But the secret of you being a very good pharmacist is constant practice. You have to be reading almost every day. But one of the challenges I think that we had when we were in school is that, someone even has the desire to read. But what is the person reading? Where can I get the content of what I need to read? And that is a challenge. There are so many books that if we were introduced to back in school, we would have been doing far better than what we are doing. But unfortunately, the books were not available. Lexicon, for instance, has always been one of the books I would recommend for every student. Yesterday, for instance, I ordered some books from Canada and it arrived. I just had it yesterday. They had intravenous infusions. That one will give you details, how you reconstitute some of these things. Do you get it? So it really helps your practice. It makes you a dynamic pharmacist, not just to come to the counter. And currently, even right now, I don't do counter work. You will not even find me in the pharmacy. Almost all the time, I am in the ward. You can be here, they're calling me, and there's a case here, can you come and have a look at it for us? They keep calling you because they know what you are made up of. And I'll advise that, look, learn every day, read every day. That is what I just want you to, anyone who wants to really do well to, have at the back of their mind. Invest in your education. Lexicon is a bit expensive, but get some money, buy it, read it almost every day. And you see, pharmacy is not easy. It is a difficult course, and I'll never hide it from anyone. But you as the individual can make it easy for yourself. If you make time what you are being taught, make time for what you need to do personally, you'll be able to do much. So with the little that I have, that is what I can say. Learn, get the resources, and make time. That is all I can say about this matter. Maybe you might want me to say something else, but that is what I can say in summary.
Thank you so much. And I have also listened to your advice for a while, and I can see how it is helping. For instance, with the lexicon that you keep talking about. Last year we met, I think, when we were doing our rotation, you came around to Tamale Teaching Hospital. Yes. And you make mention of it. So my roommate happened to get a copy of the lexicon, and I must also confess that it's very good. I recently was reading on the management, triple therapy management for peptic ulcer. Then something interesting struck that I have never seen anywhere, even though I've read on them several. I realized that, for instance, the PPIs, after your 2 weeks treatment with the triple therapy, you have to continue it for a number of days, like 18 days. And this is an information that I didn't find any other place. So I totally agree with you with the resources. And also, I think the fact that a lot of us were not aware of the right materials, as you have mentioned, because back in school, somebody would tell you that you have to know the STG, and when we got to the ground, like the teaching hospital, like what is STG? You see, but
I was surprised.
That's the information that they kept giving. I remember I even set a goal for myself when I was in like 3rd year, that by the time I complete school, I should know everything in the STG. But later I realized that STG actually virtually contains nothing, and it's kind of a book for a physician assistant to resort to, and not someone who clinically imparts. So I totally agree with you, and I hope the audience will pick value from this. And I know you are easily accessible, so I'll try and get your a link that people can access you, so that in case they need any information, they will get in touch with you. So basically, what I've learned from you today, and I want to reiterate for my audience, is that you need to know about the right materials to learn, and you need to learn as often as possible in order to sharpen your clinical knowledge and be the best at your practice. So Dr. Anakin, I'm very grateful for your time. Thank you so much for everything, and I look forward to having more of such convo with you, and even sometime maybe a group of you, so that we all share thoughts about pharmacy practice as it is now. Thank you so much.
No problem, Dr. Obed. Anytime, you can always call on me, and I'm also very happy for you to have called on me to also share the little that I have. And I it's my prayer that as many as will listen to or watch this video will be, enlightened, will be encouraged to even do more as we are doing here as well. Thank you very much for having me. Thank you too.
So viewers, we have come to the end of this particular episode. I hope you have really enjoyed this and you have learned a lot of it. Go out there and be practitioners of the word that you have heard today. If you have not subscribed to the channel yet, do subscribe to the channel, and also hit the bell icon so that anytime that we release a new video, you'll be notified. Thank you, and I'll see you in the next episode. Bye.